Hello, everyone. Thank you so much for joining us for another Health for the World Grand Run today. We have the honor of having Dr. Valdivia joining us to talk about FDG, PET-CT in lung cancer. Dr. Valdivia is Assistant Professor of Nuclear Medicine in Montefiore College of Medicine. She completed her medical school in University Central del Caribe and later completed her residency in nuclear medicine at Mount Sinai School of Medicine. If there is any question, you can write the question in the Q&A or in the chat box, and we can address them at the end of the lecture. So, Dr. Valdivia, thank you so much for joining us today, and we look forward to hearing your lecture.
Thank you so much for that introduction, Dr. Habibullahi, and it's my pleasure. I hope everyone can enjoy what I'm going to share. So, as said in the introduction, I'm going to be talking about the role of FDG PET in lung cancer management. FDG stands for fluorodeoxyglucose. And first, I want to start with some basics, of course, which are important to be familiar with before moving on to the deeper part of this talk. So I have no conflict of interest to disclose. I'm going to start, as I say, with the basics. So first of all, what is PET, right? That stands for positron emission tomography, which is an imaging modality routinely performed as a hybrid technique with both PET and CT. It combines basically the anatomical localization and morphological information from CT with functional data provided by the PET. And the imaging includes techniques that allow us also to quantify what we're looking at in terms of metabolic changes. This type of imaging technique is called metabolic imaging. And then the radiopharmaceutical I'm going to be focusing on today is F18 fluorodeoxyglucose. That's what the title says, and I'm going to concentrate on that. It is currently the most widely used molecular imaging modality in the clinical practice for both staging and restaging of several cancers, not just lung cancer. And the reason for that is that malignant tumors are often very highly metabolically active, and therefore that's going to display increased glucose metabolism and increased FDG uptake that could be detected as quote-unquote hotspots, which have higher uptake, which is measured, as I mentioned, with standardized uptake values. And that's just like the very basic of it. I'm going to talk a little bit about the radio isotope that we use, which is F18 fluorine. The half-life is just under 2 hours. It decays with emission of a positron. That's the reason why it's called positron emission tomography. And basically, what it means is that a positron is going to collide with an electron, producing an annihilation reaction. The two photons are 511 keVs in energy, kilo electron volts. These are detected by the camera detectors, and then the computer algorithm reconstructs the location of the original positron emission. So this image here basically summarizes what I just said. It's easier to kind of understand things when you see them in a picture. So basically what is happening with the annihilation that I mentioned is from the nucleus of the positron emitting radionuclide, a positron is going to be released, right? It's going to interact with an electron in tissue. In this case, let's assume that's a malignant tumor. And then the two 511 keV photons are going to be released, the so-called annihilation. Those are going to be detected by these scintillation crystals that are in the PET scanner. So those detectors, once that coincidence detection happens, it will make it possible to localize the source of the annihilation and therefore locate the activity or the hotspot, as we call them, in the body. And that's basically the essence of this. And that is the case for any radiopharmaceutical that produces images in this manner of positron emission tomography. But as I said, we're going to focus on F18 in this lecture. So then this is a picture of what a PET-CT scanner looks like. So those crystals that I mentioned are going to be located here. This is where the patient is going to be lying down. And then the next thing, right? So I described the radioisotope. Now I'm going to talk about the pharmaceutical here, which is FDG, fluorodeoxyglucose. So what is FDG? It's an analog of glucose. That's why I want to show you here the chemical structure of the molecule, right? So compared to glucose, you can see that how similar it is. Basically, the only difference is that this hydroxyl group from the C2 position has been replaced by the fluorine 18 radioisotope, which is going to make it possible, of course, that's the radioactive part of this molecule. It's going to make it possible for those detectors to detect, pardon the redundance, these areas of increased metabolism in the body. And then also very important, this F18 that is replacing the hydroxyl group in this C2 position is going to be the responsible one for this FDG getting trapped inside the cell, as I will explain, which is mainly the beauty of this type of imaging. The phosphorylated FDG gets trapped inside the cell because this F18 FDG is not a substrate for glucose 6-phosphatase. So I'm just going to continue here as explaining why is it that we see activity on the FDG PET scan in tumors that are malignant. So basically, there is going to be increased glucose utilization. That's the basic principle. And that is because of several reasons. The first one is that it's going to be overexpression of membrane glucose transporter receptors, especially GLUT1 and GLUT3. There is going to be increased hexokinase activity, which is the enzyme responsible for phosphorylating not only glucose, but FDG. And then decreased level of glucose 6-phosphatase, which is the one responsible for dephosphorylating the FDG or the glucose. So in other words, there is going to be more glucose 6 phosphate available, the phosphorylated type. And then, so once inside the tumor cells, I just already mentioned this. So it's going to be FDG converted to glucose 6 phosphate, which is not a substrate for the enzyme that is going to dephosphorylate the FDG. Therefore, is not a substrate for continuing through the glycolytic pathway and being metabolized. So this image, again, like just to illustrate what I said, you can see here, this is a malignant cell, right? So you can see the increased number of receptors, particularly GLUT1 and GLUT3, as I mentioned. So you can see here the difference between glucose and FDG. They both are going to be phosphorylated. And you can see, as I mentioned, the hexokinase is going to be increased. So there is going to be more in the malignant cells, more phosphorylation of that FDG becoming FDG 6-phosphate. And as I also mentioned, this is not a substrate for the glucose 6-phosphatase. Therefore, it's going to continue to accumulate by not being a substrate to continue into the glycolytic pathway, as well as being too polar to diffuse freely through the lipid bilayer of the membrane. So this is what is so-called metabolic trapping. So once inside the cell, the FDG continues to be there, and then that's what we image, and we don't need to image immediately. Actually, these patients are getting injected, and we wait 45 minutes to 1 hour before we take the images. So we don't need to rush an image after an injection because the activity is going to remain there and it's going to be higher in the malignant cells. This is just another image showing the difference of a normal cell compared to the malignant cell. So at a glance, you can see the increased number of those glucose receptors. And then again, what I already mentioned for the metabolic pathway trapping, that the phosphorylated FDG is not going to go into the glycolytic pathway like glucose does, and then it becomes trapped inside the malignant cell. That's basically what I wanted to show you or explain about this mechanism of FDG uptake. And then the next thing I want to do before moving on is showing you, of course, what a normal F18 FDG scan looks like. So that because I'm going to be showing you images. And you can see here, and this is, I'm showing you this is usually the typical field of view that we include from base of skull to mid-thigh. And then you can see intense physiologic activity in the brain. It uses a lot of glucose, right? You can see the liver, the spleen is excreted physiologically through the kidneys. You might be asking why, because glucose is not excreted normally in the urine, right? Unless the patient is a diabetic and is on control. So as opposed to glucose, FDG is not reabsorbed in the proximal tubules of the kidneys, and that's why we physiologically see activity in the urine. The myocardial activity is variable. Ideally, we shouldn't see it because these patients have to fast for at least 4 hours, and the fasting myocardium is supposed to be using fatty acids and not glucose, but that is really something that unless the patient gets specifically prepared for a cardiac imaging FDG, which of course is beyond the scope of this lecture, it's just too variable to comment on the myocardial activity on an FDG PET scan that is done for oncology purposes. So moving on, now you have an idea. This is like sort of a 3D image. It's called a maximum intensity projection image. So you can see kind of everything in one image. And just to get you familiarized with the normal distribution of FDG. I mentioned briefly at the beginning that we kind of have the capacity to quantify the activity, and that is done by using the so-called SUV, standardized uptake value. And I just want to show you how it's done, of course, just for your general purpose. So it's basically how much activity there is in a particular area that shows increased uptake. And this is the formula. I'm not going to dive too much into it. It's just for your own knowledge. So it's the way of quantifying. Just for a general idea, usually an SUV of about 2.5, which is more or less what the liver typically shows, is what is considered like kind of normal uptake, if you will. But that, of course, cannot be applied and generalized because it's just much more complicated than that. There is no magic number, but just to have an idea, the liver, as you can see here, which is frequently what we use as our standard, tends to have a mean SUV of about 2.5, just so that you more or less understand the number. So anything that, let's say, has an SUV of 3, 3.5, we may call it mild uptake, etc. So in order to talk about lung cancer, we need to start with a single pulmonary nodule, right? Because many times this is how a cancer ends up being diagnosed. So small pulmonary nodules are frequently identified incidentally on imaging that is really performed for other reasons. And that usually happens excuse me, in about 0.2% of chest x-rays and around 1% of thoracic CT scans. The good thing is that the majority of these solitary pulmonary nodules are benign, but in up to 20%, they could represent malignant tumors, especially in high-risk patients like smokers, right, or older patients. In that group, the high-risk group, the malignancy could approach the the risk of malignancy could approach 70%. So that is significant. And that's why these single pulmonary nodules in patients that are high risk are frequently followed. So FDG PET-CT is very useful, or could be very useful in the decision making in, with respect to proceeding to obtain a biopsy or not. I want to highlight this study that reported FDG PET-CT to have a diagnostic accuracy of about 94% in diagnosing malignant pulmonary nodules, with a false positive rate of 6.5%, which I will cover a bit what the main reasons for false positives are. And some data suggests that the degree of FDG uptake in the PET-CT can differentiate between different tumor histologies, and that is a well-known phenomenon. For example, squamous cell carcinomas tend to have significantly higher FDG uptake as opposed to minimally invasive adenocarcinoma or adenocarcinoma in situ, which formerly were called bronchoalveolar carcinoma, as well as carcinoid tumors. Those tend to have less degree of uptake, and therefore you may have a false negative result. So we always are very cognizant of that, and it's something worth mentioning when talking about lung cancer. Based on the National Comprehensive Cancer Network guidelines, when do we typically see these patients with single pulmonary nodules refer for FDG PET scan? So basically, if we're talking about a solid nodule, if the nodule is greater than 8 millimeters, then the recommendation is to consider CT at 3 months, FDG PET, or biopsy. If we're talking about a semi-solid nodule, so basically has a solid component with some ground glass opacification associated with it, if that solid component is greater or equal to 6 millimeters, then we consider FDG PET or biopsy. So these are the kind of patients we will get referred to us for FDG PET when talking about a solitary pulmonary nodule. And then, as I mentioned, there is a false positive rate, right? For single pulmonary nodule, basically what it means is showing uptake when the nodule is benign. So reasons for that, anything that is inflamed or infected can show FDG uptake. And this is a list that it's, of course, doesn't include everything, but for example, pneumonia, an abscess, tuberculosis, sarcoidosis, infective granulomas, fibrosis, mediastinitis, all of those are benign findings that could really show some degree of uptake and then give you a false positive result on an FDG PET scan for a single pulmonary nodule. I want to show you an example here. So first, as I mentioned that the first image I showed you was like a 3D. This is not. This is just a cut. These three here are the axial cuts, right? This is a coronal. These two images on top, the black and white, are the PET-only images. This is, of course, the CT that you can recognize, and this is the CT and the PET superimposed, which is called the fused image and the fusion image. So this is a semi-solid nodule. You can see here some mild activity. So based on what I mentioned, that we kind of follow what the liver shows, this is just a little bit under the liver. So this SUV is in the range of 2. It's mild uptake. It's considered mild uptake. Nevertheless, when we're dealing with nodules like these, especially semi-solid nodules, just because of the nature of the slow-growing malignancy, indolent malignancy, the uptake is typically not that high. So this definitely we cannot exclude malignancy when we see this kind of finding. So in this particular patient, there was a biopsy and it was malignant. This was an adenosquamous carcinoma. Now I want to show you another case, another semi-solid nodule. You can see here, this is an axial cut, the CT, the fused image, mild uptake in that nodule that was detected by a CT. So this patient also ended up having a biopsy, which is what these kind of lesions typically end up having, because of course we cannot rule out malignancy, and the only way to get to the final diagnosis is by tissue correlation. So this patient, on the other hand, had benign adenomatous hyperplasia. So just want to put them side by side so that you can see that it's really difficult in these cases, but nevertheless, if it shows uptake, the patient really most likely will need a biopsy. So if the single pulmonary nodule is suggestive of malignancy on an FDG PET-CT, of course, as I said, tissue diagnosis is needed. And in terms of doing that for peripheral lesions, routinely those could be sampled with just a CT-guided biopsy. If you have more centrally located lesions, those could be biopsied via bronchoscopic techniques. In terms of detecting metastases, sometimes even when you just get a referral for a single pulmonary nodule, you might already have metastases, although it's not common. So mediastinal or beyond, also that could immediately direct an alternate route of obtaining tissue, right? If you see something that has an easier target, like a supraclavicular node or mediastinal node, that might be a lower risk of an invasive procedure to the patient, and the biopsy could be obtained of that lesion rather than the primary lung lesion. I just want to show you a patient that is not, it was being followed for nasopharyngeal cancer, as we frequently see. And then, so this patient on the, this is the axial scan again. You can see here just a very small opacity here in the right lung apex, pleural-based, with some mild uptake, which was described. And recommended follow-up. Unfortunately, the patient didn't come back to us until 3 years later, and this is what happened. So you can see that became this obvious mass in the same region with very intense FDG activity consistent with the malignancy. This was a second primary in this patient, a lung cancer. Also, I want to show you at the baseline scan on top, this is through the mediastinum. So this is here a precarinal node that didn't show uptake originally. These 4 rows are the first scan for follow-up. And then on the 3 years later scan, you can see here how that lymph node enlarged, and now there is intense uptake. So important to pay attention, you know, especially, we don't know if in this patient that was the reason, but nasopharyngeal cancer is very commonly treated with radiation, and perhaps that radiation was the cause for this cancer. We don't know, but important to follow up and not wait that long, at least, you know, do 6 months, etc., to be able to catch that earlier. So now diving into lung cancer itself, just some statistics. I live in the US, so I'm going to give you the USA statistics, the latest ones. It's the leading cause of death in the United States, the second most common cancer in both men and women. And every year, more people die of lung cancer than colon, breast, and prostate cancers combined. About 238,000 cases are estimated for this year. And of those, about 127,000 deaths expected as a result of this disease. And then about 18% are of these patients are alive 5 years or more after the diagnosis. So that's not a huge number, right? And then, so most of the lung cancers are not small cell lung cancer, about 80 to 85%, which is what I'm going to be covering in this lecture. 15 to 20% are neuroendocrine, which includes small cell lung cancer, carcinoid. And the reason why I'm not going to cover this is because these are imaged with, for the most part, with a different radiopharmaceutical. And there is no time to cover both in this lecture, of course. So we're going to focus on FDG PET-CT, which is used to follow and stage non-small cell lung cancer. Okay, so this is just the same, just depicting that most lung cancers are non-small cell lung cancer, with 15% small cell lung cancer, about 85 non-small, and then of the non-small cell lung cancers, 30% are squamous, 70% non-squamous, which most of them are adenocarcinomas, and then 10% are large cell carcinoma, which is neuroendocrine. So moving on to specifically non-small cell carcinoma, what is the role of FDG PET, right? For staging, which is the first step, and this is already the patient has been diagnosed. So we're beyond the single pulmonary nodule stage. So very, very important nodal staging. It's a very important step in determining if the patient could be offered surgical resection. For something to keep in mind, anything that is very small, sub-centimeter in diameter, we may have a problem with identifying the uptake, even if it is malignant or metastatic, just because of the resolution of the scanner. But we all are familiar with that and we understand that. So, but if we have a lesion that is more than a centimeter in particular, then we feel confident, if it is negative, calling it negative. I just want to highlight this particular study that found a rate of about 26% of finding occult nodal metastasis on FDG PET. In this particular study, however, they did combine tumor size with SUV maximum, and they found that offers some predictive ability. For example, what they did was tumors that were greater than 2.5 cm with SUV max of greater than 4.35. There was an 89% chance of detecting occult lymph node metastasis. Of course, the bigger the tumor, the higher the uptake, the most probability there is of finding metastatic disease in a particular patient. So I just want to show you here a comparison between this accuracy, sensitivity, and specificity of nodal staging in non-small cell lung cancer for PET-CT with FDG and CT. So you can see here at a glance for PET-CT, the accuracy of 90% versus 75% for CT. Sensitivity 75 to 85 for PET-CT, 57 to 68 for CT, and 87 to 92 for PET-CT, and then about 76 to 82 for CT. So you might be asking, why such a huge difference? Well, I'm going to show you a case that may speak for itself. So this patient I'm going to highlight here. This is an axial cut through the mediastinum with a CT. You can see here a normal size node. In short axis, this is less than a centimeter. You can see another normal size node here in the AP window region, also less than a centimeter in short axis. So by CT criteria, these are called normal lymph nodes, no evidence of metastatic disease, which is what was done. The patient had an FDG PET scan. You can see here, by the way, this is the primary tumor here in the left lung, which shows very intense activity, right? And then you can see those two normal sized lymph nodes demonstrating increased activity. So that immediately raises the concern that these are likely metastatic, right? Even though on the CT they were normal size. So just to show you that this patient, those lymph nodes were metastatic. So again, this is the same image, just in long window, showing you here the lung cancer and the two lymph nodes in question. You can see that 2 months later, no treatment has been given for one reason or another. And then you can see that those two lymph nodes that I described now, obviously they are large by even size criteria on CT, right? And the uptake is so much more intense. And then there is a new lymph node here. So of course, I just want to show you that these were metastatic. And then if you were to do only a CT at the beginning in the scan that I showed you, And just based on size criteria, you could not call them metastatic disease. So that's the reason why we have those so-called superpowers with the metabolic activity. And we many times could detect metastasis before they are visible and obvious on a CT. So that may account for what I showed you in that table of the better accuracy, sensitivity, and specificity of FDG as opposed to just a plain CT. So just to summarize in terms of nodal staging, the role of FDG PET-CT, if you, of course, have a positive node or in the mediastinum or the hilum, then you need histological confirmation. It's not like it's positive on FDG, automatically is malignant. In that case, it was proven to be just on follow-up imaging, but you need histological confirmation. Because as it says, I have mentioned benign lesions like inflammation could also show increased uptake. If you have negative mediastinal nodes on the FDG PET-CT, those patients can generally proceed to surgical resection. The negative predictive value is pretty good, unless the lymph node is really tiny, as I mentioned, that could be below the resolution of PET. And then if you combine PET-CT with endobronchial ultrasound guided biopsy, that really can significantly increase the diagnostic accuracy of nodal staging. If you have mediastinal nodes that are suspicious, right, on the other hand, on size criteria on CT, but negative on PET-CT, you also need to do histological examination, right? We don't want to miss a possible metastatic disease simply because it's not showing increased activity, but those cases are really rare. And patients that have mediastinal nodes positive on PET, I already mentioned that, should not be denying curative surgery, right, without histological confirmation, because you could have other factors causing the increased uptake, such as infection or inflammation. In terms of distant metastatic disease, important to evaluate, as about 40% of patients with non-small cell lung cancer are reported to present already with distant metastasis. So the most common sites for non-small cell lung cancer are the adrenal glands, the bones, the liver, and the brain. So PET-CT is more accurate in general than conventional imaging at diagnosing also the presence of distant mets. And up to 10% of patients are found to have metastases on FDG PET that were not really previously detected on a CT. And it's not like, I want to make sure we're not trying to replace a CT. Of course not. We complement each other, and it's really, that's the beauty of it. So in terms of the adrenals in particular, in up to 20% of patients with non-small cell lung cancer, adrenal tumors are identified on a CT. And then we need to take into account those incidental adrenal adenomas, which are not uncommon and could also show increased FDG uptake, unfortunately. So sometimes it might be challenging to differentiate a metastasis from a benign lesion. And but you know, that capacity of differentiating metabolically active, potentially metastatic lesions from those that are quiescent and not metabolically active is very useful. And of course, again, I mean, if you have a small nodule in the adrenal, you may have a false negative result, and we always keep that in mind. In terms of the accuracy for detecting adrenal metastasis is very good for FDG PET-CT, 95%, the positive predictive value about 95% also, and the negative predictive value about 94%. So really good in that respect. I want to show you a case here of one adrenal nodule that was seen in a patient with lung cancer. And then it did show uptake. So in these cases, if it is indeterminate, and this is what happened, it's a 7-millimeter nodule, SUV 3.6, MRI was indeterminate as well, because typically what we would do is recommend an MRI in a patient that shows uptake like this on an adrenal lesion. But unfortunately, MRI was also indeterminate. The patient had a biopsy, and this particular case ended up being focal inflammation without malignant involvement. So I just want to show you how sometimes inflammation only could show increased uptake. this could also be the way a malignant or I should say metastatic adrenal adenoma may look like. So the only way to differentiate is by doing a biopsy, but at least they know what to target and what to biopsy, right? In terms of bone, so the more traditional approach, typically is bone scintigraphy, although I need to mention specifically for lung cancer, the bone metastatic lesions tend to be lytic. And for that purpose, bone scan is not the most sensitive one. It's really not sensitive for that matter. I mean, for that reason. And also overall, even for osteoblastic lesions, the sensitivity is really good in the 90% range, but the specificity is lacking usually because of the also areas of inflammation and degeneration that may take up the radiopharmaceutical and cause trouble in trying to differentiate between metastatic lesions. So for metastatic bone lesions in non-small cell lung cancer in particular, FDG PET-CT is preferred by far versus a bone scan. And you can see here how the accuracy, sensitivity, and specificity are in the 90s. So I just want to show you an example here. These are all axial cuts, and the top row is the follow-up scan. The bottom row is the baseline scan when the patient was first image. Again, axial, this is bone window. So I'm showing you here through the thorax, you can see the ribs. So here at the baseline scan, in this vertebral body, you can see no abnormality. There is no CT abnormality, no abnormal uptake. And then in the follow-up, you can see still the CT shows nothing. But look at this. Now there, at least in this, at this level, there are two very intensely avid lesions consistent with metastatic disease, regardless of what the CT shows. And, for lesions that are inherently lytic, many times we don't see them early enough on the CT to be able to call them. So if this patient was being followed only with CT, those lesions would have been missed. So you can see here the metastatic lesions, and then this is at a different level also. Originally, no abnormality. And on follow-up, you can see the intense metastatic lesion that developed that is not really seen on a CT. There is what you may call a lucency here, but this is symmetric. I'm not showing the other side, but this was symmetric. And it's just the way that particular bone looks in this patient, because in follow-up looks exactly the same when you have this intensely avid metastatic lesion. So very useful, as you can see, for evaluating bone metastases. Liver and brain. So for liver is superior in general. If you see a focal increased uptake above the liver background, that is usually concerning. And when present, uptake is highly suspicious of malignancy, and it usually is malignant and metastatic. For brain, it's another story, definitely, because I showed you at the beginning, the brain uptake is very intense. So if you're looking for a hotspot within a hot background, it's could be impossible to detect. So the sensitivity is very low, like in the 40s. So conventional CT or MRI is still considered the imaging modality of choice for diagnosing the presence of brain metastasis. I just want to show you here, this table depicts the impact of FDG PET-CT on patient staging and management for non-small cell lung cancer. And these are different studies, right? So it's like a review. You can see here the number of patients, the change of stage in %, and the impact in management. So I'm just going to take, for example, the study with the greater number of patients, 592. You can see here that FDG PET changed the stage in about 29% of the cases, and they had an impact in management in about 37% of the cases. So that's really, really an important factor to take into consideration in terms of altering the staging and the management in these patients. In terms of evaluating response to treatment. Important to note that it's recommended that to perform a follow-up FDG PET-CT after chemoradiation is recommended to wait at least 3 months. You may have inflammation, etc., in the area that was treated, especially with radiation, and that could preclude the correct interpretation of your findings. So that's the reason why 3 months is recommended. And in terms of comparing PET-CT with just conventional CT, typically it's hard when you have architectural dysfunction, morphologic distortion of the tissue, to tell if there is recurrence of disease, for instance, or if the tumor is responding to treatment. So PET-CT with FDG offers the opportunity to assess this metabolic activity, right? And therefore know whether or not there is tumor actually that is viable in the areas that are of concern on the anatomical imaging. If you have decreased uptake, that correlates very good with improved outcomes, and it is a marker of effective response to chemotherapy. If there is not change in the level of the activity, this could direct a change in the chemotherapeutic approach. And then there is evidence that if there is persistent high uptake following the first chemotherapy cycle, this correlates with poorer prognosis, that in patients that demonstrate low uptake after the first cycle, with a median survival of 12 months as compared to 34 months on those that show lower uptake. In terms of surveillance, the role of PET is really basically when there is a finding on conventional imaging. So when these patients are typically followed with CT, and then the role of PET is really when there is a finding on a CT that is not clear whether or not the patient has recurrence of disease. For example, they may find atelectasis, consolidation, radiation fibrosis, and those may be confused with disease recurrence, and then the degree of uptake definitely could be helpful in these cases. In terms of identifying disease recurrence with suspicious lesions already found, of course, in conventional imaging, so we need to take that into account. These patients already have an abnormality identified. So the sensitivity, specificity, and accuracy are depicted here. You can see the sensitivity 98, accuracy 93, specificity 82. If you have a negative PET-CT on follow-up, this is highly predictive of improved survival. So the negative predictive value of a PET-CT with FDG in these cases is really high. I want to show you here. This is a patient. Of course, you can see a malignancy here in the left lower lobe of the lung with very intense uptake. This patient was treated with radiation treatment. This is a follow-up scan. So I just want to show you when we could become helpful. So this is what was found on the CT. The patient got referred because, of course, you cannot tell if could be some components of viable tumor in this area, especially the more dense area over here in this portion of this opacity. So the patient had the FDG PET-CT. You can see here the fused image, and no very high uptake at all. So this was deemed to be just post-RT change, and that was helpful in this situation. I have another case here, similar. This is in the right lung apex, a very FDG avid mass that was treated. And then on follow-up, there was still this opacity, small, persistent. You don't know on a regular anatomical imaging if this is viable tissue or not. So on the FDG, you can see that there is no uptake whatsoever. So this was deemed just not consistent with residual disease, and it's very, very helpful. So I just want to show you how we are helping in these surveillance patients. This case I'm going to show you now. So this is a MIP, a maximum intensity projection image. This is a patient with lung cancer this is the baseline scan. This is the follow-up scan. So at a glance, you can see that unfortunately for this patient, it's not as the previous two cases I showed you. There is obvious progression. You can see worsening of the original lesion plus multiple other foci, right? So we have, as I'm going to show you in different axial cuts, you can see here at the level of the mediastinum, a very intensely avid subcarinal node, right hilar, lymphadenopathy, consistent with metastatic disease. You can see here another lymph node in the precarinal region, very FDG avid, consistent with metastasis. A new adrenal mass. Of course, this you don't even need to biopsy. This is a mass, very avid, which was not present before in the left adrenal gland. It's consistent with metastatic disease. So this patient did progress. And then I just want to quickly highlight some of the limitations. Like everything, we have limitations. You may have misregistration between the PET and CT components of the images due to patient motion or even breathing, right? So there might be misregistration in the lung bases of or the dome of the liver. Some benign lesions, as I have reiterated, can also show increased metabolism. The brain, heart, myocardium, GI and GU tract, as well as the skeleton, the skeletal muscles can show increased uptake, and they may mask a malignant lesion if there is one and may obscure it. Small lesions also may appear falsely negative, as I have mentioned, because they could be below the resolution of the scanner. Lesions that contain only micrometastases, low-grade neoplasms, and highly differentiated tumors can all be misinterpreted as benign, as the metabolism of these lesions is lower. Of course, the uptake is going to be lower. Also, the cost, FDG PET is costly. I'm just going to quickly, in this last 4 minutes that I have, talk about some challenges that are sort of recent in terms of evaluating lung cancer in particular and FDG. When using FDG, there are new therapeutic agents that have been incorporated in the most recent years to treat non-small cell lung cancer that go beyond the usual triad of surgery, radiotherapy, and chemotherapy. And those are anti-angiogenic drugs, and then targeted therapies that are called immunotherapy. So these ones have modified response patterns that may make it difficult. I will explain as quickly as I can so that you can have an idea about this challenge that you may encounter. And just in simple words, tumors that are responding to treatment could be mistakenly classified as progressing. That is the so-called pseudo-progression. And this may cause a withdrawal of drugs that actually are working. So it's important to have some knowledge about this. So basically, as I mentioned, immunotherapy has been incorporated recently to treating advanced lung cancer. And the way those work is by means of anti-PD-1 and anti-PD-L1 antibodies. And there are several that have been approved. The mechanism of actions of these antibodies is basically residing in the reactivation of anti-tumor T lymphocytes that are inhibited by the tumor itself. So they become activated, and then several studies have shown they are superior in terms of response and tolerability versus conventional chemotherapy. So that's why they're so popular now. And the responses to these therapies often present unconventional patterns. For example, if they could be underestimated by morphological criteria, and they may have delayed response and pseudoprogression due to lymphocytic infiltration and inflammation. So in other words, you may have something that appears to be getting worse when in fact it's getting better. So I want to show you an example of a case that actually it's not the case of pseudoprogression, but I want to show you this patient that got treated with immunotherapy. These scans are 2 months apart. So this is the baseline over here. This is the follow-up. You can see the intensely avid large right lung mass, which became smaller and now has areas of photopenia, which is necrotic tissue, which is good. You want the tumor to die. Then you see a liver lesion, for example, here, which actually I am showing you in these images. So these are axial cuts, PET, CT, and fused images. On the left is the baseline scan. On the right is the follow-up scan. You can see here the big lesion in the liver with intense activity. On follow-up, there is so much smaller, right? And there is no uptake. So even though there is still a hypodensity on the CT, there is no abnormal uptake. So that resolved, metabolically speaking. You can see the primary lesion. It was already necrotic to begin with in the right lung. Here on the left, it's a baseline. On follow-up, much smaller, so response. One problem is that the thyroid was okay, no abnormal uptake. You can see the intensely avid activity on follow-up scan. This is what is called destructive thyroiditis, which may be associated with these immunotherapy agents. So something to keep in mind, because these patients become profoundly hypothyroid and do need treatment with thyroid hormone supplements to be able to fix that, because the TSH are like very high when this happens and they need to be taken care of. So basically, just to summarize, the progression is a transient enlargement of the tumor or metastatic size before the regression in size starts. It's attributed to a temporary inflammatory reaction, and may resemble tumor flare. Occurs in approximately 2 to 6% of patients treated with immunotherapy, and it can occur at any time. With any of the immunotherapy agents that are available and approved by FDA. And the mean number of days based on RECIST criteria from baseline to progression is about 74 days. And then from baseline to response is 170 days about. So basically you see the progression and then you start seeing the response. This is a clinical call. Basically, you may consider repeat biopsy if it is not clear to the referring physician whether or not the patient is improving. But if the patient is clinically responding and doing well, the clinician may just continue the same treatment and follow up closely with subsequent scans. And that's basically what it is. That's why I say it's a clinical call. Many times we just tell them that. For example, lastly, this patient had 10 months on the immunotherapy, clinically doing well. So even though you can see on top here, this is the baseline, and you can see in the bottom the follow-up scan 4 months later, this lesion here obviously shows more uptake. It's a larger area of increased activity, as well as this lymph node in the left hilar region shows much more uptake down here on the follow-up scan, but the patient is clinically stable. This patient could just be observed and the scan follow-up, and hopefully will catch that regression time in the follow-up scan when the patient is getting better. These are just a list of some of the complications of immunotherapy. As I mentioned, thyroiditis, I showed you that picture. You could have exacerbation of sarcoidosis, splenic sarcoidosis, autoimmune pancreatitis, hypophysitis. So a lot of inflammatory, because the same body is responding to the tumor as well as could attack normal tissue. And just lastly, this is the summary of basically what FDG PET-CT could do in terms of management for non-small cell lung cancer. So a diagnosis, right? You need to know how likely it is that it is malignant, and then proceed to tissue diagnosis or not. And then for staging, so of course the primary tumor, nodal staging, metastasis, as I have mentioned, that is going to be very important in terms of eventually determining if the patient is having surgical resection or oncological treatment. And then for follow-up, mainly evaluating response to treatment, very important. If there is a need for restaging, for reconsidering the treatment that is being given. And then in order to assess metabolic activity, in suspicious lesions that were already found by anatomical imaging, in terms of determining what the next step will be. So that's a summary of basically what FDG PET-CT, how is it used in terms of staging and management of lung cancer. And I thank you so much for your attention, and I'm happy to answer any questions that are there, if there are any.
Thank you so much, Dr. Valdivia, for your session. I personally learned a lot from this session. As I can see, there is no question in Q&A, but I have one question for you. So, well, actually, I think there is some question. So there is one question from Tamakulo. So it's been asked that does pseudoprogression strictly occur only in patients receiving immunotherapy, or can it occur in those receiving chemotherapy?
It's been documented in our experience with immunotherapy. Just regular chemotherapy is more straightforward. You see progression, that means progression. Yes. It's just there are different mechanisms of treatment, and I kind of try to explain it as concisely as I could why the reason is it's basically the lymphocytic infiltration and inflammation that is associated with these immunotherapeutic agents that causes that transient enlargement, which is really an inflammatory response, right? Rather than a progression. And then eventually that will take course and the patient will improve also metabolically speaking.
I see. Thank you so much. So I also had one more question. I was wondering that if there is any theranostic agent commonly used in for treatment of the non-small cell cancers.
No, clinically at the moment, no. We are we are doing at the moment for prostate cancer. We're doing for neuroendocrine cancers, but not for non-small cell lung cancer. I hope that that will come available to patients soon.
Let's see. Thank you so much. Thank you so much, Dr. Valdivia, and thank you so much, everyone, for joining us today. We look forward to having you very soon, and thanks again for joining our grand run today.
Oh, my pleasure. Thank you so much for your attention. Have a great day.
Same here. Have a good one. Bye, everyone.
Okay, bye-bye.